Today's episode requires that you have an open mind because we're going to talk about some very nuanced approaches, some unconventional ways that experts like my guest, Dr. Tyna Moore, are using semaglutide, Ozempic, GLP-1s to treat things like cognitive decline, arthritis, addiction, brain fog, prevention of dementia, and midlife weight loss. So if you've been kind of sitting on the fence or curious about how these drugs seem to be so popular and why everyone's talking about them, yet at the same time you're terrified about all of the side effects you've been hearing about, today's conversation is going to open your mind. We are going to talk about microdosing, the very lowest dose of some of these drugs in a way that's super affordable, as little as $30 a month, and not necessarily for weight loss, although that it can be used for weight loss. But my guest today is a very outspoken advocate, not just for the use of these drugs, but for the proper use of these drugs. And in fact, she's probably one of the loudest voices on the internet that I can think of who's saying that most doctors are over-prescribing these drugs. They're giving people too high of a dosage, and that is why we're seeing such negative side effects in some parts of the population. But we're going to break it all down today. So if you've been wondering about the side effects, if you've been wondering if in fact you might be a candidate and how people are being able to afford these drugs and can you get them from a compound pharmacy, all of those questions and more will be answered here today on The Chalene Show. Dr. Tyna Moore, my guest, is a licensed naturopath physician. She has spent several decades studying longevity and regenerative medicine. She's an expert in metabolic and regenerative health, and she's become one of the most well-known advocates for the unconventional use of Ozempic. And she's here with us today to break it all down. Why is it that people seem to be more divided over the conversation regarding Ozempic, GLP-1s? I mean, even more divided over this than it seems they are politics.
It's interesting, isn't it? It's been a really wild ride, truly all-consuming. Like, this is all I've been looking at, hardcore, and how it relates to anything and everything I can look up when it comes to health and physiology and hormones and you name it. And I've been talking about it on my platform, which is, not as big as yours, but it's a decent size. And the divisiveness is crazy. It was really shocking to me at first. And even when I bring up benefits of GLP-1 that have nothing to do with weight loss, and the word weight loss is nowhere in the post or the content, people still cannot get away from that. And I think, honestly, it's reflective of obesity bias that we have in this country. There's a whole lot of speculation that I have in my brain on both sides, but I think that people get really uncomfortable when the idea of there being some kind of easy out in their brains, that's the way they're seeing it, and they don't understand the nuance of what's really happening downstream when people are utilizing these peptides appropriately. So I really do. I think it comes down to a frank obesity bias, which I know is going to make some people listening very mad when I say it, but I don't know how else to explain it.
I would agree with you. It seems to be that. Semaglutide, are we correct in calling it a drug, or is it really a hormone? Is it a peptide? And what is the difference between those things?
So it's a signaling peptide hormone, which is confusing, but it basically anything in the body. So it's a chain of amino acids. That's what a peptide is. Semaglutide is bioidentical to the GLP-1 that is naturally occurring in our body, with one caveat. It's been tweaked so that it has a longer half-life. Naturally occurring GLP-1 is secreted in our gut and in our brains, and it has actions throughout the entire body for various reasons we can talk about. But the semaglutide version, the Tirzepatide, these more adulterated versions are bioidentical other than the fact that they have a longer half-life. So semaglutide will last a week in the body instead of a matter of, minutes or even shorter. So hormones are meant to signal in various different ways throughout the body, and their actions are meant to be brief and potent. And so when we supplement with a peptide version, an injectable peptide version, we're asking the peptide to stay in the body longer so that it has its impact for longer.
With that in mind, does it make sense that we start to include semaglutide, GLP-1s, even in a compound form and perhaps even in different dosages? Does it make sense that we start including that when we're talking about bioidentical hormone replacement, especially for midlife women?
Absolutely. So the way that I got interested in this is I was hitting a wall with my health, and I, like you, have always been really fit and active and, kept my appearance is up and was doing really well at it and utilizing bioidentical hormones early on. I mean, I've always been doing very small, appropriate physiologic doses of hormones, even in my 30s, because I'm someone who has endured a tremendous amount of stress in my life, and I burned myself out very early. So I needed some of these hormones a long time ago. And that was during the time period clinically in my practice too, where, 20 years ago, that Women's Health Initiative study came out saying that hormones were dangerous and going to kill us. And those of us in the knew that was a garbage study. Like, we knew where it was flawed, and we were like, well, we're just going to keep prescribing because our patients are having phenomenal benefits. And now, just recently, I don't know if you saw, but they just came out using the same data set saying that study was garbage and flawed. And hormones are it's not only are they safe, but they're necessary, and it's really unsafe to not be on them. It's like, gee, I didn't know. So we all ignored it. We're like, we're going to keep dosing our patients and giving them the benefits they need because we know better. And when I started researching GLP-1s, I was like, I think there's a deficiency happening here. And so I looked into it, and it turns out that there's a deficiency in those who are the ones using it most: type 2 diabetics, those who are obese, those with fatty liver. And I was like, well, I wonder if there's a low-grade deficiency happening in others. And what would not the side effects, but what would the symptoms of that be? Like, what would that look like? And as I was hitting this wall in my health, as my hormones were shifting, I endured a tremendous amount of stress the past few years because I pushed back on the narrative really hard with a big platform. So it was not a fun time. And the cortisol that I was bathing in from all of that stress was destroying my metabolic health. And I was having happen to me what I was seeing in so many of my patients, which was this sort of middle-age thickening, I call it. And you've probably seen it with so many of your girlfriends. It's like all of a sudden you just sort of like you thicken up and you're like, what the heck is going on? I'm doing everything right. And erroneously, we try harder. I know I've seen your content recently where you're like, I'm pulling back on the intensity because it's just driving that cortisol bus. Yeah. And whether I tried harder or less hard, it didn't matter. I could not seem to figure out what the heck was going on. And the way I kept describing it to my friends was, I know that this peptide has impacts in the brain. I found all the data. It's neuroregenerative. It quells neuroinflammation. I know from my experience clinically and the medicine that I do and the medicine I've studied that the downstream impacts of brain inflammation, especially in middle age, that's really what's driving a lot of hormonal imbalances. Menopause starts in our brains. It does not necessarily start in our ovaries. It starts in signals from our brains. And so I kept telling everyone, I feel like I need to flip the switch on the breaker. Like when in your house, when you blow a fuse or you blow a breaker and you go and flip it and the whole room comes back on. I was like, I need to reset the switch, and nothing I'm doing is working. And I have access to stuff that most people don't have access to. My whole background's in the regenerative medicine space. So I have things I can put in my veins, that have miraculous properties. None of it was working. And so I decided that if this was a signaling peptide hormone, much like other signaling peptide hormones in the body, like oxytocin, insulin, leptin, ghrelin, all of these are in the same family. They're not steroid sex hormones, but they are similar in the way that they signal and the way that they are used in the body. Neurotransmitters are signaling peptide hormones. They're all kind of in that same family. I thought, what if I supplemented a physiologic dose? What would happen to address a potential deficiency? And so that's what I started doing.
The time, was there any research? Like, were you like, was there somebody who was, paving the way or talking about this? And because it feels like a lot of people now are talking about microdosing it and all the other benefits, depending, of course, on who it is you're working with and the protocol they're putting together for you. But I feel like a lot of biohackers are talking about this now. But at the time when you started doing this for yourself, you're just looking at the research and the mechanisms and saying to yourself, it would just make sense that this would work. Was that a little sketch? I mean, were you nervous? You were kind of like making yourself a guinea pig.
Well, so I couldn't find anyone that was microdosing it. Now, people say they're microdosing, but they're actually just low dosing. I'm talking microdosing. Okay. Like I'm talking starting with tiny little doses here and seeing what happens, right? I also know better. You can't just use these as monotherapy in isolation. GLP-1s standalone is not the solution. This was...
Can you repeat that phrase?
So just monotherapy where you utilize one thing and hope for the best. It would be like if you put on estrogen and you were like, I'm going to do bioidentical hormone replacement. I'm going to do estrogen at a low dose. It's like, yeah, no. you have to have all the hormones, right? We need the progesterone and the testosterone. We don't just use GLP-1s as a standalone. There's other peptides we use. We want to make sure most certainly that people are on bioidentical hormone replacement. We have data that just came out recently. It was a small study showing that women on bioidentical hormone replacement had significantly better outcomes with semaglutide than women who were not on bioidentical hormone replacement. So we know that these things harmonize. So for me, it was just adjunctive. Like it was just something I wanted to add in. And so I called up all of my friends that I knew, all my colleagues that I knew were using it in clinic. And all of them did not know what, they were like, what are you talking about? And I said, how are you using it? And they're like, well, we're using it at low doses for weight loss. Everybody was using it at low doses for weight loss or weight maintenance. And I called the compounding pharmacy friends, same thing, same story. They're like, yeah. And my theory was if someone's really metabolically sound, like women like us who are active, we lift weights, we take our walks, we get our sleep, we mitigate our stress, we eat our protein, we get our sunlight. My theory was that we would just need a touch, like a very small amount. And that might just sweeten the deal, because what that thickening is it's insulin resistance. At the end of the day, it's cellular insulin resistance. It may not show up on labs for a year or two, but it will eventually. And so my theory was, well, I'm just going to take a small dose because what could it hurt, right? Like there's literally no side effects at low doses. All of the side effects were happening at high doses. And so I thought, well, I've got nothing to lose here. I'm going to give it a go. And it was miraculous. I also, most importantly, was using it because I have psoriatic arthritis and my autoimmune disease was cranking. My brain fog was like some next level stuff. And I, like you, am a boss babe and I have a lot of business to run and I have a lot to do. And my brain was not keeping up with what I needed to have happen. And my team was starting to be like, Tina, are you okay? You're not remembering everything on time. And my ADHD was starting to go into overdrive. And so I was using it for reasons outside of weight loss. Sure, I had 15, 20 pounds I wanted to take off just kind of throughout the midsection. But more importantly, I just wanted my brain back and my body to stop hurting. And so that's what I was asking my colleagues. And none of them had any clue what I was talking about. None of them were using it for that. Straight up. I mean, since then I have friends who are now doing it. But at the time, everyone was like, what? You're going to use it for what? I'm like, this study just came out on cardiovascular disease. We have data on this. We have data on this. We have data on kidney disease. Like, what about using it for brain fog, for depression, for pain, And that was, I feel like I was really the one who just decided to, go out on a ledge and give it a go. So,
yeah. So let me ask you this. What mechanism is it that's having an impact on, for example, autoimmune disorders, like arthritis, for example? What is the mechanism that's making that happen?
So there's GLP-1 receptors in our bones, our muscles, our synovium, which is the covering of our joints, our cartilage. Like there's GLP-1 receptors everywhere. There's also leptin receptors and insulin receptors and estrogen receptors. So like our bones and our joints and our muscles are very active, much more so than we've given them credit. We kind of look at them as just like mechanistic tools in our body to move things. And so GLP-1s have an anti-inflammatory impact on the brain, which downstream is going to have a huge impact on pain and on your immune system overall. And because, like I said, everything really starts centrally. Secondly, it has an anti-inflammatory impact throughout the body, and it sits on our immune cells, which is wild. It literally binds our immune cells, which that part was the most fascinating for me. When I figured that out, I was like, game on. I'm trying this. I really am excited because as we hit middle age, we have a shift in our immunologic function, and some of our immune cells shift to a more inflammatory pathologic version. And that's what starts the whole cascade of that insulin resistance is we become, it's called inflammaging. So it just happens, even with our best efforts, it just happens to us. And the more fat you pack on through that process, the more inflamed you become because fat is really pro-inflammatory at the end of the day as those fat cells get full. So it's just kind of a hot mess that feeds forward. And I was trying to figure out how to abate it. Like, how do I flip the lever and make this stop? And I can honestly say that GLP-1s are doing it really beautifully.
So much of the, I guess, pushback and the negative press that we're seeing about GLP-1s, by whatever name they're going by, I think I've heard you say many times, it's not the GLP-1s. It's the way that we're dosing them. It's the way they're being prescribed. It's the lack of a protocol from practitioners who are just like handing these out like candy without regard to the whole person. Can you speak to that a little bit? Because, even when I told my audience I was going to be speaking with you today and asking them for their questions, it's the same kinds of things we're seeing in the headlines over and over again. Just this fear, first of all, that there's a shortage, that you're going to gain back all the weight and a lot more, and then all the negative side effects and the risks associated, the things that again, they grab us because we see them in the headlines. So can you talk to us a little bit about what's the difference in the way you're talking about using these as a tool versus what you're seeing the general population being subjected to?
I think people are being overdosed straight up. So if you look at any of these signaling peptide hormones I mentioned, and you were to overdose somebody on them, they would die. And we would not blame I guess some would blame the peptide, but more often we'd blame the dosage and the management of that prescription, right? Or conversely, abuse of it. Is it the doctor writing an abusive prescription, the patient abusing it, and not being compliant? There's a whole piece of patient compliance no one's talking about. Everybody wants to put blame on the peptide, and I'm like, how about the people who haven't changed their eating habits whatsoever and are not lifting weights? But we can get to that. So I think that there is an overdosage situation happening. I don't think that most people need these high doses. What happens with the brand names is they come in pre-filled pens that are dispensing pens, and those pens have a predetermined dosage. You can't play with them very much. And so you have to take what you get. I believe that the starting dose with most of these pens is too high for a lot of people. Not everyone. Some people actually are so deficient in GLP-1 that the starting dose of these pens is very appropriate. But for many, it's too high. And then they're ramped up very quickly over a period of 16 weeks where the dose is essentially doubled every month, way up into very high doses that I think are sending people over the edge. And so somewhere in there, they're getting their appetite crushed. And when you crush someone's appetite completely, they stop eating, or they just eat less of what they're used to eating. So instead of eating 3 bags of Doritos and some cheeseburgers, they might eat 1. They're just eating less of the garbage foods. And so we have a real mess there because those folks, sadly, at the end of the day, they come into this metabolically busted. And then, 2018 data showed that 94% of U.S. adults were metabolically busted. And I can't imagine.
What was that number? What percentage?
94%. And that was 2018 data. So imagine what's happened since 2020.
It ain't good.
I live on the West Coast. We were locked down a long time, and a lot of people gained a lot of weight. So, and the stress of all of it, right? The stress of all of it drives the cortisol. So everybody came out of that period of time. I think
we were forced indoors. The gyms were closed. The beaches were closed. Like anything that related to health, we didn't have access to.
Right. So I think a lot of people, what do you do when you're home and you're terrified? You bake and you prepare and eat comfort food, right? So I'm not putting blame on anyone, but we all came out of it with like the COVID-15, COVID-20, even with the best efforts. And just the sheer cortisol bath of that will drive this metabolic dysfunction. So anyway, we've got people sitting in this realm. The people most often getting these peptides are going to be prescribed in a conventional manner are going to be those who are obese, diabetic, type 2 diabetes. I want to clarify it is also helpful for type 1 diabetes. And they aren't necessarily being counseled on diet and nutrition. I will say, though, I have watched every single webinar I could get my hands on that's been put out by any medical establishment. And all of them emphasize lifestyle management, nutrition, exercise first and foremost, and then adding in these peptides adjunctively. Just because not every doctor is doing that doesn't inherently make the whole system evil. I want to give credit to the doctors who are, because there's a lot of doctors trying. Patients are not compliant. Trying to get a patient to lift weight. I've been trying to get people to lift weights and eat meat for like decades, and it is like pulling teeth. People don't want to do it. They don't know how to start. They're scared of it. They're intimidated. You understand. And so I think that people are not being given the proper tools, or maybe the tools are just not available, or the education isn't available, and they're not protecting their muscle. If you crush your appetite, you eat just less garbage food than more, and you don't protect your muscle. At the end of this journey of using Ozempic, Wegovy, whatever, they're going to be so much more metabolically fried out than how they started. So they're not going into it good, and they're going to come out the other side wasted away with absolutely no muscle. And then without exercise. So the data is actually really compelling. In the last few months, we've had really good studies coming out showing that those who exercised during their journey actually had better outcomes when it came to going off of the peptide, titrating down. They did not regain all the weight. The ones regaining all the weight are the ones who essentially did nothing. They just took a peptide, wasted away, and then regained all the weight once they stopped.
If I understand what you're saying, it's not that the peptide is wasting away the muscle. It's the lack of lifestyle. It's the, okay, I'm taking this GLP-1 that is suppressing my appetite. I'm eating less, in many cases, kind of less of the not so great food. I haven't changed my lifestyle. I'm not lifting. I'm not prioritizing that because, like, why would I? Right now, I'm losing weight and it's kind of easy. And so it's not the drug. It's not the peptide that's causing people to lose money. It's the lifestyle or the lack thereof, the lack of change to lifestyle. Is that accurate?
Yes, because any calorically restricted diet sustained for long enough will result in 20 to 30% of lean mass loss. Bariatric surgery, this is on par with bariatric surgery. There's a 20 to 30% lean mass loss. And that doesn't necessarily mean muscle loss. Also, it's mass loss that they're often analyzing. The other part no one's talking about is when you have fatty infiltrate in your muscle due to metabolic dysfunction. It is very common for your liver to get fatty, your pancreas to get fatty, and your muscle to get fatty. Your muscle becomes marbled as you go down this pathway towards type 2 diabetes. When insulin resistance is getting resolved, so these peptides are regenerative, healing, and anti-inflammatory. They're literally healing the person's metabolism while they're on it. It's not just a Band-Aid, like take this drug and you get these results and you go off and the results are gone. It's actually healing them for the long haul. They will come out the other side better than they started in a more healed state, a more metabolically healed state, which I think no one's talking about and is really compelling and exciting.
Is that pretty universal, or is that depend again upon dosage and treatment?
I think that's universal. I just think some people are getting way overdosed. And so, they're getting thrown over the other side of things. But no, it is 100% regenerative and healing.
And what is the regenerative mechanism? What are we permanently making those changes or improvements?
Well, so peptides in of themselves are often regenerative and anti-inflammatory. So whether you're looking at BPC 157 or, any of the others, they insert themselves where they need to go and then they do their job. And so the way that this works is it actually makes your cells more insulin sensitive. So that insulin resistance, that leptin resistance, all of that slowly but surely gets addressed. Your leptin can't work properly without enough GLP-1 in the system. So I think a lot of folks are having other things remedied in their body, which is leading to weight loss. It's not just the appetite suppression. It's a whole orchestra of other things that are happening that are favorable in the body that are leading overall to a healed metabolic state. And so some of these folks need to stay on this a long time because they've been in the metabolic hell for a long time, right? And so it's not just go on it a few months, get off and everything's good. They might need to be on it for a long time or maybe life. They may have fried out their metabolism, but getting the dose right is the key. These can be used long term, and just like any other hormone, I would cycle them. But let me get back to that because I want to talk about the muscle. When you address insulin resistance in a patient, one of the first things that happens, especially if they start lifting weights, is that the fat in their liver starts to dissolve. Most people don't realize they're walking around with fatty liver. It's a huge epidemic and it's very dangerous. And it leads to liver cancer ultimately. So it burns the fat off in the liver. You burn the fat off in the pancreas. You're also burning the fat off that's marbling the muscle. So of course the muscle's going to end up weighing less at the end. And the muscles can become dehydrated because the one side effect of this is it does sort of make you forget to drink water, which I will say can happen. So when these folks are remeasured, they're being measured with less fat, marble infiltrate, and less potentially water in their muscles, which is going to make it way less. So people are screaming muscle loss. These are regenerative to the muscle. They've actually been shown to help with angiogenesis, so to bring more vasculature to and throughout the muscle, which is amazing, which will deliver more nutrients when the person's eating nutritiously dense food like protein full of amino acids, which will lead to muscle protein synthesis, the anti-inflammatory impact on the muscle. And then there's actually cellular signaling pathways that are stimulated that lead to muscle protein synthesis. So these peptides really, in essence, when you look at how they work, are muscle regenerative, not muscle wasting. The wasting is due to the caloric restriction.
Okay, so from what I understand, people generally reach a plateau or there's almost a generic titrating up of the medication. So once someone starts, as you mentioned, they're going to continually increase their dose. And I assume that it loses its effectiveness over time. Is that accurate? So for these people that have to be on it indefinitely, are they indefinitely titrating up?
No, they stick to a dose. And what the studies are showing is that 4 years out even, people are maintaining their weight loss, I think, without increasing the dose. So 2.4 is the max height of dosage. But a couple things. I think that long term, I think it's healing the metabolism. So their metabolic system starts to work better. Hopefully they can titrate down or maybe just stay on a very low dose. That's what's happening, I think, in a lot of clinics is people are hitting their goal, their weight loss threshold goal, which I'm also arguing of using it for totally different reasons. But if weight loss is the conversation, they're hitting their goal and then smart doctors are titrating them back and finding the minimum dose necessary to keep them at that goal. And as that metabolic health starts to heal and maintain that healing state, their bodies are working better. They are better machines. They are better metabolic machines. They go back to a more healthy, normal state than, and some of these folks are being born this way. I mean, that's a whole other conversation. But if a mother's metabolic health is a disaster, her offspring are coded, like they're epigenetically coded and with a significant increased risk for obesity and diabetes down the line. So we're a couple generations into this mess, right? So no, the dose doesn't keep going up, and hopefully people aren't just staying at that high of dose. And there actually was some data that came out of Italy. It hasn't been published yet, but I was so happy to read it last week. If they finally said, why are we dosing everyone so high? Why don't we just give them the minimum dose necessary to achieve the results we want? And I know there's a lot of smart doctors out there doing this too, because I see them on YouTube. I talk to them. You get the person the goal that they need. Things are working, right? Everything's working. We're achieving what we want, whatever that may be. Maybe it's lowering of blood pressure. Maybe it's reversal of PCOS. Maybe it's weight loss. We hit that goal dosage, and then we keep them there. And then we start looking at how can we cycle this like we do other hormones? And also how can we titrate this back to what's the minimum necessary dose to achieve the results, to continue to achieve the results that we're looking for. So I think it can be used very differently. And I think doctors are starting to realize that. I'm hoping this message gets out more and more people will start to consider that, because I think they were just going with the standard of like, well, this is what the study said to do, so this is what we're going to do. That doesn't necessarily mean that's the best dose for everyone. Not everybody needs to go up to 2.4 by any means. And smart doctors know that.
I think that there is, I'm sure you would agree, there's this excitement in the medical community where people are just excited to prescribe it to everybody because it's a bit of a money grab to some extent. And I hear a lot of the comments I'm reading from my community just saying like, but what about long-term studies? GLP-1s, we've been using them for far longer than what most people realize. I mean, they weren't on my radar until probably a year and a half ago, but they have been used for many, many years. So what do we know about their long-term effectiveness or the risks long-term?
So semaglutide's been out for a couple of years. Tirzepatide is newer, and I hear those people's concerns, and I have heard that from physicians as well. We don't know what they do. The family of GLP-1 agonists has been around for 20 years in clinical practice with millions of prescriptions written on drugs like exenatide, liraglutide. There's other drugs that came before this. They unfortunately required like daily injections, and compliance was very low because who wants to do that? Who can even remember to do that? The newer drugs have longer half-lives, so they don't need to be injected as long. Now there's oral pill form, which I have not seen amazing data yet on if the pill works better than the shots. But I have a feeling that they're going to create something that is going to be a very inexpensive, easy to administer pill in the not too near future. And we have safety data going back on GLP-1 agonists very far. So for decades. So this isn't like a totally new thing. It's just a more modern version. It's like, a drug grows up and they hone it in a bit better. So the side effects are less. It's a little more elegant with each iteration. And then Tirzepatide is a dual agonist. And so you've got a different mechanism piggybacking on top of the GLP-1 agonism, which is showing really great impacts on visceral fat and overall weight loss, metabolic function. It's just kind of a step up from there. It's not always better. Some people have actually worse times on Tirzepatide than they do on semaglutide, and it's much more expensive in some cases. But either way, I think both are especially if we start talking about some of these lower doses. And to answer your question about longevity, I think that with any hormone, we're going to see receptor insensitivity. If we bombard a cell with any hormone or any peptide for too long, the receptors will start to cleave off. And although I'm not seeing it in the data, and some of the obesity doctors I've talked to are not complaining of it, I am hearing about it from some compounding pharmacists that are saying people are calling, saying it's not working anymore. They want to bring the dose up. When I talk to folks, and I just got off the phone with a colleague and she was saying, I've got 2 patients, they've hit a plateau. She's doing very, very low dose, but she's like, they've hit a plateau. Do I bring up the dose? And I said, are they lifting weights and hitting their protein macros? And are you using, bioidentical hormone replacement in conjunction? And she said, no. And I was like, well, if they won't comply, you cut the prescription off of the GLP-1 because they're going to be effed at the end of this if they don't start lifting weights and really protecting that muscle. And why would we crank up the one, I go back to that monotherapy conversation, why would we crank up just the one peptide when I, as a longevity holistic physician, am trying to be the conductor of an orchestra. I don't just want a bass drum. And Ozempic is a great big bass drum, but we need all the other instruments working in harmony. So we need to be doing all the things, and they're all non-negotiable in my book.
I love that approach.
That's how we have the longevity of it working. I want to keep this at the lowest dose possible. I want to cycle it so I can use it for the longest time period. I want to be on this for life because it's doing remarkable things for me that I haven't found anything. Wow. And the price, when you're low dosing it on a compounded version, it's very, very affordable. So it's
like what?
Well, gosh, it depends on the dose, but I think for me, I'm paying like $30 a month.
Wow.
Yeah.
So can you share with us some of the unconventional ways that you are applying this as a treatment for your clients, your people you care for?
Yeah, so I've only got one person on it that we're actively trying to reduce weight and treat type 2 diabetes. And that's my dad. And he's a big guy. And he's really, he had gone way, way, way too far down that pathway. And what I don't think most people understand is when you go into the doctor and they tell you you have type 2 diabetes, all that is a magic number. It's a number that has been brewing for 10, 20 years. You have been walking down the path of metabolic dysfunction for a long time. At the end of that pathway, if you survive the hurdles of cardiovascular disease, kidney failure, blindness, toe and lower extremity amputation, ultimately it will lead to dementia and cancer. So when people are finally diagnosed at type 2 diabetes, and this is not to upset anyone, but you have significantly fucked your metabolism by then. It has significantly been destroyed. It's not a subtle thing. I know it's been normalized because it's so common. And I know a lot of doctors themselves have it. And so they say, oh, your fatty liver is normal, your insulin resistance normal. Oh, and now you just hit type 2 diabetes. Here's some metformin. That is a disaster of metabolic and mitochondrial health at that point. And so my argument always is, why aren't we treating people on the front end? When the woman shows up in my clinic, the 50-year-old woman shows up and she's built like you and she's been doing everything right for a long time. And we know she's got all the other, assets on board with the, hormone replacement, everything else. And she says, I gained 20 pounds out of nowhere. She's going to gain another 10 pounds or more in the next decade. And on it goes. And in our system, we treat people when they're way over here. I treat people over here. I get them early. I get them when I see the glimmers. And so I'm using GLP-1s at very low doses in women like you and I when we get that 20 pounds of bloat. I'm also using, which I know somebody will argue, but I'm using compounded. I'm not taking away from the supply issue. There's plenty of compounded semaglutide out there.
The supply is actually with the pen, if I understand that correctly.
That's what I understood a year ago. I can imagine it's probably changed. I know they just had a big fire at literally a week ago. There was a huge fire at Novo Nordisk at I think it was their offices. I don't think it was their plant, but something's going on. I don't know. And also, you know, capitalism, if you decrease supply, you increase demand. So who knows? But I do want to argue for the fact that I would like to address a woman or a man or any patient when they're starting to have the glimmers of insulin resistance. That's where I intervene, because I don't need them to get heart disease. We don't give somebody blood pressure medication after they've had a heart attack. We address it when the blood pressure starts to creep up. So it's preventative medicine. That's the medicine I practice. I'm also using it for PCOS, inflammatory bowel disease.
Really?
Oh, yeah. Like amazing results with Crohn's and ulcerative colitis. I'm using it for depression, cognition, high blood pressure, just cardiovascular health in general. Early onset dementia, glimmers of dementia. Something that people don't appreciate is when one of your loved ones or yourself starts to get very staunch and stringent in your mindset, meaning they become less adaptable, they become less willing to try to, like a good example is when my mom can't make the computer work. And instead of even trying, or I know she's a smart woman, instead of even trying, she just immediately, forget it. I can't do this. That's an early sign of
intolerance for frustration.
Yes, that's an early sign of dementia. And it's because you don't have plasticity working in your brain, which I want to talk about really quick. These peptides have a neuroregenerative impact and an anti-inflammatory impact in the brain. We don't have anything that does that well. This is really phenomenal. And what happens with that, and what nobody is appreciating, is when a person goes on a GLP-1 and they start to have this neuroregenerative impact, not only does a lot of the noise go away, the ADHD symptoms for me improved significantly. I actually started losing I don't know how to describe it. I would ruminate on things and I didn't even realize I was ruminating. One example is I would overpack all the time. And now I don't feel any need to overpack. I don't feel the need to do a lot of things I used to do that I didn't realize were a problem, but that was my brain getting too strict on me. I was losing plasticity, and neuroplasticity is the ability to learn new things, to wire new pathways. And these peptides allow for neuroplasticity to occur. And so when the person's on it, they're actually in a window of time that they are having a neuroplasticity experience. And so that's the most awesome opportunity to start implementing new lifestyle changes, right? This is when we start to really get people to hone in on taking better care of themselves, because they're hardwiring new pathways. And it gives them also the onus of control gets returned to the driver's seat. That's something no one's talking about. When people are on GLP-1s, they suddenly feel far more in control of their lives, their bodies, their eating habits, everything. We're seeing alcohol cessation, smoking cessation, drug use cessation, online shopping. My followers are messaging me saying, I used to have a severe online shopping habit. It's gone. So it's really phenomenal. And if we use this as a window to hardwire good habits, right? That's the ticket. So while you're on them, if you continue just to eat garbage food but eat less, you're not rewiring anything. Let's rewire folks while they're on it for better habits. That's a really phenomenal opportunity that I don't know of any other drug or peptide that does that. So there's a lot of good benefits here that people are not hearing or discussing or even understanding. It's nuanced. And I don't think most doctors prescribing it know most of this stuff.
And the dosage levels that you're talking about, are you finding that your patients are experiencing some of the common side effects we're hearing, like nausea and vomiting and gastroparesis?
Not at all.
And do you think that's dosage dependent?
It's completely dosage dependent. Yeah. So that is, well, now your nausea centers of your brain do have GLP-1 receptors. And I think some folks have a richer supply of receptors, so a richer bed of receptors. So they may experience more nausea from it. But the gastroparesis issue is, we need to talk about this. Those at highest risk for gastroparesis are type 2 diabetics, because their vagus nerve is being sugared and it's being destroyed. And I think a lot of these folks are sitting on the edge of gastroparesis already, low grade. They're experiencing it as burping, distension. They're getting put on, the little purple pill and being told to, avoid acidic foods or whatnot. And then you give them a whomping dose of a GLP-1, which is the standard, and boom, they get pushed over the edge. Now, that gastroparesis is transient. In most cases, it just resolves itself as the GLP-1 gets out of the system. So I haven't heard of anybody being permanently damaged. I know the headlines like to say that, but if you could permanently get yourself there just through your type 2 diabetes is my point. But you keep the dose slow and low. And I had a few patients it was funny. I had 2 patients. They both said the same thing. They were like, yeah, I threw up the other morning and then I threw up again. And I was like, well, that's the GLP-1. And they go, oh, I didn't even think of that. I thought I ate something bad. I'm like, yeah. We got to back the dose down. So it's, we don't need to go into these crazy lands of high doses. I will say though, if they're not metabolically optimized, the low doses don't work.
What does that mean? Explain to us what you mean by metabolically optimized.
So if you don't have good muscle mass, if you're not doing all the things that you and I promote all the time, then you don't get the results with the low doses. And so those folks hit a wall. They may lose a few pounds and then they plateau and they're like, well, it's not working anymore, doc. We got to up the dose. And I'm like, oh, no. You need to do all the things. And when you get all the things handled, then the weight loss will resume. We can slowly titrate up the dose, but I'm not keen. I don't have anybody even on the starting dose except one patient, my dad, and even him, we've gone very slow and low and he's not up to 2.4. So, but he's not doing anything. He's sitting in his chair still. So until he gets off his butt, the needle's not going to move or I'm pulling the peptide. But for most folks, they lose sort of the bloat that they need to lose when they're on a very low dose. They lose the bloat and then they get to what I call their fighting weight. They're just like, I'm good. Now, if we want to crank the dose and induce some nausea and induce some constipation or induce some vomiting, we probably could get extra weight off. But that weight doesn't want to come off, or they're needing to metabolically optimize themselves better. They need to work harder on the other things.
Let me go back to a conversation that I had recently with an individual who is really overweight, clinically obese, and they were talking to me about their concerns related to a GLP-1 and related to the risk of cancer, the risk of, all the things that we've talked about, and the fact that we just don't know long-term the side effects. And of course, this wasn't someone asking for my opinion. It was just a conversation we were having. But in my mind, I was thinking, but we do know for a fact the long-term risks associated with staying at the weight that you're at. We do know all that adipose tissue around your midsection. You are at risk of all-cause mortality. And there's no question about that. So it was just like, in my mind, of course, they weren't asking for my opinion, but in my mind, I'm thinking, I don't understand. You've been carrying around this much weight in his own explanation for more than 20 years. So you're at risk of, heart disease and fatty liver and, the list goes on and on and on. And I guess it's maybe the media has done such a great job of saying like, these risks we don't know and covering up the fact that obesity is in and of itself one of the most dangerous things you can do. And we know that.
Yeah. So obesity, that's the thing. Okay. So let's talk about the thyroid cancer, the pancreatitis, the gastroparesis, all of these things. This is the part no one's telling everyone. Pancreatitis, the number one cause of pancreatitis is throwing a gallstone. The number 2 cause of pancreatitis is fatty pancreas, which comes from being obese and having busted metabolic health. And the third cause is from rapid weight loss. So we're talking about a group of people who are already sitting on the edge of pancreatitis, because those who are most at risk for throwing a gallstone are your curvy, high estrogen women who are a bit, overweight, and they've, I think of them more, the way we learned it in medical school is like more of that cherub kind of shape and, curvy and high estrogen, fertile, middle-aged, kind of that woman, which is so many women, right? That woman is at high risk for gallstones. And so when you put somebody on a very calorically restricted diet and they stop eating, so that we don't need to get the dose up where we crush the appetite. We shouldn't be doing that. They should still be wanting to eat. But it happens, right? That's what's happening. Crush the appetite, decrease the intake of food. As the caloric restriction occurs, the gallbladder sludges up because it's not being asked to work as often. And then these people might still be crushing really high-fat foods. High-fat foods on GLP-1s don't mix well. So they might still be crushing high-fat foods. Their poor gallbladder's like, dude, we're already sludgy and slow. We've already got some stones in here. And then, bam, they throw a stone into the pancreatitis. But in the SELECT study, the study that was just finished up at the end of last year that showed profound reductions in cardiovascular disease, the pancreatitis risk was as high or equal to the control group. So that conversation's sort of been put to bed. That is a side effect of it being done wrong, and a person not being closely monitored or a patient not being compliant. The thyroid cancer, the group most at risk for thyroid cancer is folks who are obese. That's the biggest group of that at risk for thyroid cancer. The second biggest group is type 2 diabetics. So we've got folks who are already, again, at risk, but it's been put to bed. Like the data that just came out in the past few weeks is showing there's just no correlation between thyroid cancer and taking GLP-1s, even longer term. Like they're doing meta-analysis on all the studies, and they're just not finding a causative link. The thyroid cancer black box warning that everybody gets so excited about, it's funny because like it's on rats, and it's on rats that were given super high doses, and these rats already are prone to developing this type of very rare it's rare in humans, medullary thyroid cancer, very common in rats and rodents. And in fact, the control group also got medullary thyroid cancer. It's very rare in humans, and we have no cases of it happening in humans. Again, there's correlative data, but they're looking at people who are already at high risk for thyroid cancer. You see what I'm saying here? So anyway, if you have a family history of thyroid cancer, or you yourself have had any type of thyroid cancer, of course, everybody talk to your physicians and be concerned. If you've had any history of gallbladder issues or gallstones, be concerned. And you can do this, but that doesn't mean you throw the baby out with the bathwater. It means close monitoring, which all doctors should be doing. Like people shouldn't be buying this stuff off the internet and shooting it into them and hoping for the best. I've seen people do that. I have actually many friends who've done that since my podcast came out, and they all end up in a world of trouble. So a little too much of this, if you don't need it, can really lock your stomach down for a few days. And it's very uncomfortable. That's not gastroparesis. That's just your gut slowing down severely and you having a lot of dyspepsia. So there's also I just read a study, that big JAMA study that came out that said like 900% increased risk of pancreatitis and 400% increased risk of this and that. They actually did a counter study to that just got published. And their argument was all of this data was on patients' health charts. They were just looking at ICD-10 codes, diagnostic codes over a long term of this sect of patient charts out of this one group. And it was correlative. It wasn't causative. Interestingly, the one doctor finally said what I was thinking. He was like, well, how are these people even being diagnosed? Were they officially diagnosed through imaging, or was the doctor just palpating this upper right quadrant and saying, oh, you got gallbladder issues? You know what I mean? Like we can make diagnoses off of symptoms for sure. We don't always need imaging, but it's not good sound data to be making these very extreme claims about was the point of this recent study that came out that countered it pretty darn well. Basically everything that everyone's concerned about, that the media has been going on and on about, has been put to bed by the most recent data that I've been looking at.
And we'll do our best to link to as many of those studies as possible, because I know there's people who are watching, listening, and they actually want to see those studies. So we will link to those in our show notes. A reduction in cardiovascular disease, is that a mechanism of the GLP-1, or is that because of the weight loss and the reduction of inflammation, all those other biomarkers?
It's probably both. The group in the SELECT study were middle-aged, overweight folks who did not have diabetes, which I find to be a little bit of an oxymoron, because I bet if they looked at their insulin levels and some of their other metabolic markers, they would see that they probably had pre-diabetes, because you really, and I'm not saying this to judge anyone, you really cannot live with obesity for very long before it ultimately will turn into metabolic dysfunction. It's just how it goes. That's the natural course of the process. You get fat cells to fill, and they get inflamed and they become insulin resistant. That's just, so they were looking at potentially pre-diabetic folks. But anyway, they found a 20% reduction in severe cardiovascular outcomes, which was very exciting. And I totally agree with you. The question is, was it the weight loss? Was it the peptide? I think it's both. But they actually just came out, which I'll get you the link for. They just came out and announced that irrespective of weight loss, these folks were having improvements in cardiovascular health. And that's what I've been trying to say is a lot of the things that I'm sharing. Yes, decreasing obesity is going to have wonderful outcomes on a variety of systems in your body, but the impact and the way that the mechanism of these peptides work and the way they bind is independent of fat loss and weight loss. So I think you're getting both. I think it could be both, right? We're seeing, because we know that for every inch your weight your waist circumference increases, your brain shrinks a centimeter about. I mean, that's kind of the going knowledge. So, and if you have obesity and type 2 diabetes, you have a 4 times increased risk of developing Alzheimer's and dementia. So I think it's both.
Talk to us about the myth of type 2 diabetes. Like, I think there's this general consensus that it's definitely someone who just really looks obese. If I'm not dramatically overweight, I don't have to worry about diabetes.
It's not true. So there's this concept of skinny fat or thin on the outside, fat on the inside. And that's how I used to be. I was very thin and I was in my 30s and I felt like if I fell down, I was going to shatter. And I had just come out of like doing 2 medical programs concurrently and raising my daughter by myself. And, it was just a really tough time. And I remember getting my labs back and seeing glimmers of metabolic dysfunction. And when I say glimmers, I mean, you look at all of the values together. A good functional medicine doctor will be able to do this. They look at them all together and they're like, you are headed down this path. That doesn't mean it's frank and it's there yet. It means all of these things are adding up to you being on the path. And that path ends with all those terrible things I mentioned. So I thought, well, shit, I've got metabolic dysfunction. I mean, and what was the number one solution? Put muscle on. It's that simple. Like when you're just sitting in the glimmers of it, I was already low carb. I was already eating high protein, low carb, which in and of itself, a low protein diet sustained for too long, like the carnivore diet done too long, can actually induce insulin resistance. So I probably was doing that a little bit coupled with severe stress, and then add to it, I had no muscle mass. I was just fat and bone. I still fit in my prom dress from high school, but I was just bone and fat, right? So I think that's around the time I started following your content. And I was like, I got to lift some weights. I got to learn to deadlift and squat and build a booty. This is not going to go well if I don't have some muscle. And I knew going into menopause that I wanted to be muscled up because I knew it was going to be a bit of a bumpy ride, having watched my mom go through it and, other people in my family that I loved. I was like, that sounds like a disaster waiting to happen. So I want to go into it strong and with a good slab of muscle on my body.
Speaking of inflammation and insulin and cortisol, when I was kind of in the end years of perimenopause and experiencing that, like that, thicker through the middle, like my face was rounder. I just like, okay, I'm going to work out even harder. I'm not going to tell anyone that I'm like doing all this HIIT training, but I'm just going to like double down on the HIIT training. I'm going to do super intense boxing classes and I just went crazy on the high intensity workouts. And then I ran across some research where they were looking at high intensity athletes who are also sustaining a super high heart rate for long periods of time. And the study showed that their insulin levels, their cortisol levels were that almost mirrored someone with Cushing's disease.
Oh, no.
And I'm like, no matter how much we worked on my cortisol with my naturopathic doctor, I just couldn't get my cortisol down. And when I saw that study, I'm like, I know I'm not like considered an athlete, but I'm training like one. You know what I mean? And so what if I just stop my body? I'm not saying that everyone needs to stop doing high intensity interval training, but I had reached a point at which it was, it just didn't have the same impact that did on other people. That should reduce your cortisol levels. For me, it was increasing my cortisol levels. I've been doing it for too long and the body that's how it responded. And so once I stopped doing all the interval training, that I think made a big difference in my overall cortisol, amongst other things too. I want to interrupt for just a moment to say, if you are someone who's trying to figure out what you need to do differently because you're dealing with all the things that we've been talking about in this episode, you want to get your cortisol down, you're sick of doing the high impact, or like you've tried all the workouts and you just need to reduce your stress, I'd love to invite you to become a part of my 2-week challenge. It's called Myself Again, because you want to feel like yourself again, maybe even better. It's very simple. We're just going to walk together and I'm going to help you reduce your cortisol. It's free. All you have to do is enter your email address when you go to myselfagain.com. Okay, back to the show. About the question of cortisol and inflammation, like what comes first? Do you find that if we can reduce inflammation, we have an easier time of reducing cortisol?
I think the cortisol is driving the inflammation in most cases. So you were doing what I've done it to myself, and I've seen so many patients come in. I can't tell you how many patients I would tell them, you have to stop going to Orange Theory. Like, it immediately has to stop. Like, this high intensity nonsense has to stop. This is why I love strength training, because strength training can be as slow and low as you want it to be, right? Like, you can have as much rest time between sets. You can play with the weight. There's lots of variables to be played with that don't rev that metabolic process. It's really damaging when, especially, it's interesting. I've seen patients with very low cortisol. I tend to run very low cortisol. I've sort of fried out the circuits completely. Just the slightest surge of cortisol, it just sends me into a tizzy. It just derails my hormones. And then there's the other schools of thoughts where they want you to do high intensity interval training because we need to get the cortisol receptors to respond. So we got to crank the cortisol. And I have just found across the board that women just puff up when they are driving their cortisol. And, you have to look at the fact that, like, for you had just come out of that situation with your father-in-law. I mean, a tremendous amount of stress, right? We're enduring, especially women, especially middle-aged. I know your kids were growing and like flying the coop. Like, my daughter, moved. She's an adult. I have a 24. God, she's 24. It's like these are transition periods, and we may have been getting our oxytocin and our hormones balanced in a way of being caretakers to our children, and now they're gone. For me, I closed my practice, and so I was no longer actively doing what I was doing every day. I was over here doing much more computer work and online stuff, and these transition periods, I think, are very hard on middle-aged women, especially as our hormones shift, and then we're just trying harder and harder and harder. And I think that cortisol revving is driving the inflammation, and that ultimately is just crushing, totally crushing our metabolisms. And so for me, I'm like, I'm doing everything right. My labs look perfect. I'm doing everything right. And I'm clearly insulin resistant. My waist circumference is increasing. If your waist circumference, the magic number is take your height, divide it by 2, whether it's centimeters or inches, who cares? Take your height, divide it by 2. You want your waist circumference to be less than that. That number is the red flag zone. And so as I was creeping up to that number, I'm like, dude, this is insulin resistance straight up. How do I get the insulin resistance down? And also the other thing is that GLP-1s actually play on our dopaminergic system. They play on our HPA axis. We don't entirely know how, but I have noticed a significant reduction in my cortisol surges since I've been on it. I don't run around with that like low-grade anxiety I had all the time that I didn't know I had until it was gone. And so I think there's other factors at play, and it's not as simple as getting cortisol down or inflammation down. Again, we have to harmonize the orchestra and look at all the players, and exercise is a big one. Like, you have to find what works for you. I think the one thing consistently across the board that all middle-aged women should be doing is strength training. The intensity of that really depends on the individual in front of me, because some people cannot handle any intensity and others need much more of it, right? It just really depends on how much vitality they're coming to the show with. And I have little piles of ash on top of my kidneys that should be adrenal glands. I'm not coming with anything. So I'm just trying to preserve what I've got. And if you work out and you find yourself puffing up and swelling, you find yourself exhausted, you find it dysregulating your sleep, all of that is going to, maybe you want more wine. For me, I start to crave, if I overdo it with exercise, I actually start to crave sweets and alcohol and things that I wouldn't normally have a drive as much for. And that's a big signal that you're probably driving the cortisol ship too hard.
Wow. I hear so many people saying that these GLP-1s are kind of a miracle drug. Do you think if they're used and dosed properly, if they are, if you're doing it the right way, and you've got a whole series on that, don't you?
I do.
Okay, so then before I forget, because I will, how can somebody, you've got like a 3-part series about like how to do this the right way. And is this for practitioners or is it for the general population?
It's for everyone. It's actually a 4-part video series. So part 1, I talk about beyond weight loss. I talk about a lot of the different benefits that GLP-1s bring that have nothing to do with weight loss. Part 2 is the big scaries. I dispel a lot of the big scaries. Part 3 is that the dose makes the poison. So I dive a bit deeper into that conversation. They're all pretty short videos. And then part 4, I talk about the big pitfalls people are doing wrong, which is just they're not protecting their muscle. But it's a great series, and it'll be more elaborate than what we've done here. So people can grab that. It's on my website. It's at drtyna.com. It's Tyna. And you can also find it on my Instagram at same Dr. Tyna. And then I've got a whole podcast series on my show, the Dr. Tina Show, where I have gone into a lot of literature. I did a whole one on orthopedic concerns, knees, joints, bones. I basically just take the cool studies and talk about them. And so there's, I think, 6 different episodes there that you can listen to.
They're so good too.
Thank you. I'm trying. I really feel, to me, I feel like there is a propagandized push to vilify these peptides, and we could speculate on where it's coming from. We know for a fact that the snack food companies are concerned, fast food companies are concerned, joint replacement companies are concerned, dialysis clinics are concerned. All of them have come out and said this, because when you correct for metabolic dysfunction, that's something I need to say. I've been beating this drum for a long time. My mentor, who passed away in 2013, he brought to my attention the importance of metabolic health back in the 90s. So I have been beating this drum for as long as I can remember. This peptide to me was like this thing that came out of nowhere that fit perfectly into my entire platform of what I've been talking about. I know a lot of my followers were like, what is she talking about? What? She's talking about Ozempic? She's been telling us to strength train and go outside and eat meat. Like, what's going on? And I'm like, yeah, guys, used appropriately in conjunction with all the things, it's really a freaking miracle peptide. And done appropriately, I think it has the potential, honestly, I think it has the potential to save the trajectory that we are on as humans, because we are on an extinction path. And I know people don't want to hear that, but we are very much running into some devastating consequences down the line. And I think we're starting to see it most notably with our boomers. And we're seeing it manifest as, they're either dying of heart disease or they're ending up with dementia and they're not remembering our names. But this next wave, this Gen X wave, are you Gen X? You're probably in there with me. Yeah. I mean, man, our group is a mess. Our age cohort is a hot mess, and the long-term results of this are going to be devastating. And not to mention what's happening, like I said, with our children coming up. And I'm not saying everybody should be on GLP-1s, but with a prudent physician who knows what they're doing. And I've had a lot of followers say, my doctor really wanted to put me on this and said I was a great candidate. And I was so scared until I listened to all your content, and it changed my mind. And now I'm doing it, and I'm 6 months in, and I am forever changed. Thank you. Like, this woman found me on the street the other day and started crying. She was like, thank you for what you're doing. You are saving our generation. And I was like, whoa, that's a heavy one, but thank you. But I think that just getting the information out, there's a way to do this differently. It's not the peptide's fault. It's a management and dosing issue.
I have to say that it's really remarkable how unafraid you are, how unapologetic you are about speaking up regarding something that, like you said, has been vilified and which other people at face value might think, this doesn't even make sense related to all the things that you've been teaching for all these years. But it's about looking at this from a very nuanced point. And I love that about you. Like, that's why I dove into all of your content. I'm like, it's facts over fear. It's looking at, nothing is black and white. Nothing is. And it is whole person. And we have to look at everything in that way instead of just like shutting our ears and, refusing to listen to other possibilities, and those nuances that are, frankly, can save lives.
Really can. I'll leave with this. The data coming out around Parkinson's and Alzheimer's is phenomenal. And for the people who are beating the drum of how terrible this is and how angry they are about it, and they're so seemingly concerned about everybody else, which I don't know about you, but my health information I've shared, I've been very transparent, but like, it's nobody's business if I don't want it to be. And what you do with your body and your health is nobody's business either. And we're not talking to anyone about their risk tolerance, because you just said it. Living with obesity, especially severe obesity, is really, really devastating on everybody in the family. So I really hope that these people who are so militantly against this, who just have such a staunch, line in the sand, like these are evil and this is the lazy way out, I really hope those people don't ever end up with any of the conditions that this GLP-1 has been so remarkably treating well. Like I really pray for them that they're never put in that position where their doctor says, what would be a really great therapeutic for you right now is you're losing your memory, a GLP-1, but they can't hear it, right? They're so vehemently against it, they won't be able to hear it. I don't want that to happen. And I don't want it to happen for the people around them, because that's what's happening. My followers are messaging me, telling me that they're constantly being shamed for using it, even though it's changed their life significantly. And they're having to deal with their office workers and their family and their friends. Everybody's shaming them. And I'm like, it's no one's freaking business. Like,
yeah,
that's
Jeez,
their
that's
risk
what it's going to take. For those who are interested in working with you, following you, I'm going to put all of your contact information in our show notes, etc. But for the person who's listening, watching, is like, I am very curious. I want to work with a physician who understands these nuances, who understands how to start me on the lowest dose possible, and maybe even they're looking at it for reasons other than weight loss. How do you suggest that they find a practitioner who's as caring and perhaps even as knowledgeable as you?
It's a hard question. I was hesitant to even ever talk about this stuff because I'm like, oh man, finding a doctor to do this right is going to be tough. But I do have a program at the end of that 4-part series. I have a course, and this course is going very well. And it's about 50% doctors that are in there right now, or healthcare professionals trying to learn more. There's a whole module in there on how to find a physician. And I think education is the key. So the better educated a patient can become, go listen to all my free content, because there's at least 10 hours of free content, right? Go listen to all that and present the argument to your doctor. Come in kindly and come in educated. And doctors are usually keen to listen. I know that there's been a very big push, and I have my reasons why I think it might be, but the compounded versions are being vilified as well. They seemingly do not want people on them. And so a lot of the traditional standard MDs are staunchly saying, no, I will not prescribe a compounded. But some people are able to start on the standard, brand name drugs or peptides at a very low dose, at the starting dose, and they're doing just fine. They're having great results there. So that might be an option for some people. If you really want a compounded version and you're looking for this more complete protocol, my course is a great place to get educated. Also, looking for a naturopathic physician, a longevity medicine doctor. These doctors are generally going to be out of pocket. And the other peptides that they're going to use and the hormones are generally out of pocket. And so this can be a little bit cost prohibitive, but that doesn't mean you can't start. I've got plenty of people in my program that are starting with their general primary care physician. They're getting the lowest dose possible of the pens, of the brand name prescription, and they're doing beautifully. And then they're learning all the other things themselves, because a lot of this stuff is available over the counter, the other peptides that I like to use in conjunction. So there's ways to do this, is my point, but it starts with the patient becoming very educated. You can't just call up a pharmacy and say, hey, do you microdose? And you can't call up a doctor and say, hey, do you microdose? They'll think you're crazy. And I'm getting a ton of calls from pharmacies and doctors saying, are you crazy? Why? What are you talking about? What are you telling these people? So I'm trying to navigate this myself and stay out of trouble. But your best bet as a patient always is to become empowered through education, and then come in kindly to your doctor and present what you have. And if they won't listen to you, go find another doctor. And if they will, great. You guys can get more educated together. But it's a process. And I think that's the case that, with any physician, you got to do your homework. You got to come in with your knowledge base, and you have to be an advocate for yourself first and foremost.
Dr. Tyna Moore, thank you so much for sharing your knowledge with us. I will put links to how to reach out to her, how to make sure you're following her, especially on YouTube. Great show there, as well as Instagram. Again, thank you so much for sharing your wisdom with us today.
Thank you so much for having me. This was so fun, and I'm so glad to connect with you finally.